Good evening, everyone. I'm Peter Tawil. Welcome back to our webinars. It is our second series of webinars since we first started on DentLinks. It is my pleasure to present to you tonight a topic of importance and something that we talk about a lot in implant dentistry, the implant macrogeometry, surface texture. Tonight we'll be talking about peri-implant bone stability and the prevalence of peri-implantitis around different types of implants. Also, we'll be introducing a study that we completed in our office comparing 3 different types of implants. Looking back retrospectively at completed cases, successfully completed cases that we have done, it's sometimes very hard to discern a difference between a natural tooth and an implant when the implant was done with the respect of bone environment, with the respect of 3-dimensional positioning, with the respect of soft tissue and bone biology and bone remodeling. Here in that case, for example, it's hard to tell which one is an implant and which one is a tooth. Now, with the revealing X-ray, we know that the right central incisor is the implant. Now, the question I ask myself is, why did I get this good result? Is it because of the macrogeometry of the implant? Here in this case, we used a 3i implant, which has a polished color, internal connection. Is it because, had I used another implant, would I get the same result? Or is it because I used this implant that I got this result? Another case that was very nicely completed with the beautiful respect of the pink and the white aesthetic scores. It's also hard to tell which one is an implant. The radiograph shows us that this is a left central incisor, this is the implant. Yet again, we go back to the same question. Is it the implant itself, here in that case, a bone level Straumann, or all the other factors that we respected properly? Here in that case, where we replaced 2 missing laterals with dental implants, and the 2 implants had 2 distinct macrogeometries. The one on the right side of the patient is a Nobel conical implant, and the one on the right is a Nobel select trilobe connection. 2 different connections, 2 different peri-implant macrogeometries, same brand. However, the response on both is a bit different, as you can tell. Some bone back, dieback of the bone on the distal side of the first implant on the right side. Same here also on the left side. However, clinically, how relevant is that? Go back to the clinical photo. We have a very impeccable result with great white and thick aesthetic scores. So what is the effect of the macrogeometry on the clinical level? Let's see also a case of missing lateral incisor. Both were replaced with 2 implants with distinct macrogeometries. Here, one is a Nobel trilobe internal connection on the right side of the patient, and the other one is Straumann bone level. Now, one can argue and tell that all these implants were placed in the aesthetic zone, but replacing single implant. And more or less, the bone is always guided by the peak of bone, or the papilla is always guided by the adjacent teeth. However, it's important to note that both implants respond differently. You have some dieback of the bone on implants and others that don't lose, let's say, bone in the first year in function. And we wanted to know what is the effect on the clinical level. One case that we inherited, and it's really a pleasure to work with an environment that has been in a practice that has been using implants and placing implants for more than 35 years now. It's really privileged to work in this kind of environment, and we get to see cases on the long term. Let's say, for example, this case, a patient came in 1995 with the avulsion of a central incisor. It was an accident. Back where the days where implantology was still, something that is quite common, but the whole understanding of aesthetics and the new principles of implants in the aesthetic zone were not quite established back then. We placed implant where the bone was, and implants were mainly to give function more than just also mimic or be as natural teeth. So back then, what was done was obviously the restoration of the neighboring fractured teeth and placement of an implant where the bone was. Obviously, as you see the photograph here, the implant is placed way apically. If you follow the principles of proper three-dimensional placement nowadays, this implant is a Nobel BioCare or Brennemark back then machine surfaced implant, placed not ideally. This is how it healed. This is a couple of years later with the provisional crown. This is the final in 1999, ceramic crown. Patient also underwent a orthodontic treatment meanwhile. Now, this is in 2001, and this is 2014. As you see, there's a migration of the papilla on both distal and mesial side. The case is really improving throughout the years, and this is a long-term follow-up. This is some 16 years post-implant treatment. Now, the patient came back in 2015, where I inherited the case and placed an implant in the premolar area. He also asked to have some recontouring, gingival recontouring of the anterior teeth, just to improve a bit the aesthetics. So we agreed on doing a small static crown lengthening without touching, obviously, the implant, and trying to match the gingival levels in a better way. Obviously, in us, a full thickness flap was raised. We did an osteoplasty, ostectomy to properly contour and set the proper biologic width. This is the suturing right after surgery, where we were able to properly level the gingival margins. This is 2015 final result. Patient was thrilled and very happy. With this very small, simple gingival procedure of crown lengthening, we were able to really match properly the contours and give him a better aesthetics. This is the X-ray showing in 1998, the situation. And yet 17 years later, 2015, the same situation. And knowing that this is an old Brennemark implant with external hex connection, with a machine type of surface. So with our current knowledge of macrogeometries, this, as far as the connection is concerned, this is the connection that has the most microbial leakage, that is prone to more dieback of the bone and socialization and cratering and losing bone. And yet again, this implant stands the test of time. It's been here for 17 years and stable. Also, one can argue that the papilla is being preserved by the fact that the patient had both natural teeth on both sides. But the question we ask ourselves is that if the implant was really that bad as far as the connection and macrogeometry, on the long term, results would have been much worse. And the same question I always ask myself when I see these cases, 10 years, 8 years, post-implant treatment and post-prosthesis fixation, and you see no bone loss. I mean, literally no bone loss. And you always scratch your head and say, wait, but these are external hex implants. These implants should lose bone if we follow the literature. And a lot of the new coming knowledge come in and incriminates this kind of connections and this kind of macrogeometries, and they all blame it on the connection. So all the implants that were placed should have lost the bone till the first thread, and then eventually lose bone. Well, all these implants, they're standing still. The bone is still very stable. So there must be another factor. Here again, in some cases, we see bone gain 11 years post-loading, in a phenomenon described by Goodacre in 1999. Same here, 2002, 2010, 8 years, very, very stable bone. Now you still have this dieback till the first thread, and then a very stable result throughout time. Now this dieback, how clinically relevant is that? Do we observe any kind of difference on the clinical level? 2000, 2010. Now some may argue, say, oh, you have a dieback of the bone till the first thread. This might show. Obviously, let's see what kind of implication on the clinical level this has. So the question we ask ourselves, what are the parameters involved in peri-implant bone response? What is the ideal microgeometry of an implant? Can we compare peri-implant bone remodeling and the occurrence of peri-implantitis on different implant systems? So basically, we're introducing our study where we compared 3 different brands of implants and the bone remodeling around them and the occurrence of peri-implantitis, all placed in the same patient in similar clinical situations. So what is the importance of macrogeometry of implant and surface texture on this peri-implant bone response? And the question I've been asking myself, is there a difference on the clinical level in regards to standardized pink and white aesthetic scores, meaning standardized measurements with photographed as standardized, showing a difference between all these brands of implants? Because nowadays, with marketing and driving our practice, we should have a scientific quantification of a difference. If someone shows you on an X-ray that it looks better, let's see how clinically relevant is that. So peri-implant bone stability is dependent on many factors. I think we all know that by now. It's depending on the ridge anatomy, on bone quality. Is it a ridge that needs augmentation? Is it a bone quality that is of poor bone quality? Obviously, the bone does not resist as well. It's depending on the prosthetic reconstruction. Am I using a cement or a screw retain? Do I have leakage underneath a screw retain multi-unit, let's say, type of prosthesis? And we all know that. Bone biology. What type of bone biology are we dealing with? Macrogeometry. The surgery-related factor, meaning how was the surgery completed? Was it with respect of bone? Was it overheated? Did we place the implant in the right 3-dimensional position? The patient itself, is the patient a smoker? Is the patient a good candidate for implant? Is the patient a diabetic, a controlled diabetic or not? Is the patient coming in for recalls every 6 months? Occlusal overload. very important factor that really does affect the peri-implant bone stability. So what we're trying to study is the effect of hardware and macrogeometry that has on all these other factors. Is it the determining factor or just one out of all these factors? In our practice, we had the privilege to use all these implants in all our patients. Throughout the years, we started using the Brandemark system. And then later on, the Nobel Select system came in, which is in a highly polished color, the first 1.5 millimeter, and a rough surface. Then about in the years 2007, 8, 9, 10, like this, we had a the trend was to go towards grooviness and roughness to the top to preserve as much bone as possible, micro-threading. Yet this again showed that also this could be a problem, when you have an exposed roughness of the implant surface, or you have a dieback of the bone in the first thread, then you have exposed surface. Then these implants were more prone to peri-implantitis. We also used the Straumann bone level with an internal connection and a limited platform shifting. Later on, we also used the ADVA system that has a system that has a very nice design with a micro thread, with a limited polished color, conical connection, aggressive apical part for tapering. And also the implant that we've been using lately is the Nobel conical implant that really sums it up all with the new type of connection, limited polished color, grooviness, and a good taper to catch and grab more bone stability as far as primary stability. So all this implant have different macrogeometries, surface textures. Some are just regular thionite, other are SLA or SL active surfaces. The implant abutment interface is quite different. Each connection is different. The thread pitch is different. Platform switching or not, micro threading or not, all these do have an effect on peri-implant bone. Let's go to the literature and see what the literature says about all these different parameters. Let's start in with implant abutment interface and what we call the biologic width establishment. Classically, Adele in 81 has described that a successful implant has a mean vertical resorption for the first year in function of 1.5 to 2 millimeter, or in common language, what we call the dieback of the bone till the first thread. And this is all observed with non-platform switch implant. Back in the days, these implants were machine surfaced, they were not rough surfaced. So an exposed implant surface back then did not cause any problem. Also, classically, we look at the studies by Abrahamson in 97, in where they compared Astra, Brandemark, and tissue-level Straumann. Back in the days, in 97, Astra also had a tissue-level implant. They found out that with 3 different implants, they had the same epithelial and connective tissue compartment. So the geometry of the implant seems to be of little importance in terms of the peri-implant bone, soft and hard tissue healing. So there's a somewhat what we call the biologic width establishment that also has been described by Boozer in the 90s. And this is common to all implants. It's important to note also that the fact that removing and so disconnecting and connecting again an abutment more than 4 or 5 times, like they said in the study, can provoke this kind of establishment of biologic width. That's why nowadays we try to go into the concept of one abutment one time, try not to disturb this implant abutment interface, and try to limit as much as possible the dieback of bone and establishment of this biologic width. Later on, with literature, Jung in 2008 talked about the implant abutment diameter in regards to the implant position in bone. So here, three different implants position in the same model, a dog model. You had implants placed equicrestally, ones that are placed subcrestally, and ones that are placed supracrestally. So he found out that the experimental implant did not show radiographic differences in marginal bone loss placed submucosally or transmucosally. Where the implants were placed 1 millimeter below the alveolar crest, the greatest amount of bone was observed initially. However, in this situation, similar to equicrestal level at 6 months, meaning the implants placed subcrestally first lost more bone, and then eventually at 6 months was about the same. Wang in 2008 compared two different implant systems. One is ankylose and one is Brennemark. When he placed the ankylose in an equicrestal position, he lost more bone than when he placed it 1.5 millimeter subcrestally. And the same phenomenon occurred for a Brennemark implant that is designed to be placed equicrestally. But when it was placed subcrestally, it lost less bone. So he described this phenomenon as the narrowing of the funnel, that this type of implant position might allow for better soft tissue support, even with platform matching implants. Now, ankylose we all know, has a huge platform shifting implant, shifting the horizontal component of the vertical component of a biologic width into a horizontal component, limiting that establishment of that biologic width and therefore limiting early implant bone loss. Now, it's important to note that these implants were not loaded. So how can we mimic the real world, especially also in a dog model? Now, Donovan in 2010 has took it clinically and evaluated 138 implants on 50 patients. Now, they were placed roughly 1.5 millimeters subcrestally, and he found that he lost very little amount of bone on all these implants. So some implants are designed to be placed subcrestally, some implants are designed to be placed equicrestally. We took it to just an observation of our cases, where some of the cases implants locked at maybe 0.5 millimeter supracrestally, so we just left them there. Others we placed equicrestally, and moreover others that were placed subcrestally. And we tried to compare 3 to 4 years down the road with radiographs. Is there any difference in between all these positioning? Not so much. On the clinical level, not at all. So positioning of the implant is important. However, how clinically relevant is that? Implant configuration is something that, or the type of the connection is a parameter also that was studied. This is a study by Ku in 2012, where they evaluated 20 external octagonal connections versus 20 internal octagonal connections on 40 implants and 40 patients. It was a nice study design, comparing the split mouth technique on the same patient, using it, so the patient used as a control, and comparing just the only parameter to compare was the type of connection. They found out that obviously the internal octagonal connection was more in favor. Here you can see 0.08 in the means of bone loss. Obviously, also the angles for the internal connection was much less of bone loss. Nice study done. Now, statistically, it's probably something that you can have a statistical significance in it. However, on the clinical level, it's hard to discern a difference between 0.08 and 0.61. So half a millimeter is something that we really can quantify in the clinical world. However, literature do favor internal connection. And going back to the classical study by Hansen in 2003, where they compared flat-to-flat connection, which usually responds with a bone loss that is markedly concentrated around the coronal margin, versus an internal connection where you have a more evenly distributed at a deeper level on the implant surface. And these are finite element analysis. Let's talk about platform switching for a moment. Classically, Tarnow described with this phenomenon of cratering around implants that the minimum implant distance, inter-implant distance, should be 3 millimeters. And what you should expect from a soft tissue height above 2 narrowing implant was about 3 to 3.4 millimeters. In 2010, this review article has probably outlined very nicely the platform shifting or platform switching effect. They concluded that platform switching may preserve inter-implant bone height and soft tissue level probably in a better way than platform matching would do. Obviously, switching the components of a biologic width will help preserve that kind of bone around implants, but that preservation of peri-implant bone may not necessarily improve aesthetics. This is one of their conclusions. Another study also done by a Spanish team, in where Tarnow also was a co-author, they found out clinically that with platform shifting, they could rethink or revisit these numbers that they found earlier on, meaning the inter-implant distance could be revisited to about 2 millimeters, and the bone loss that you should expect around peri-implant was 0.6 millimeter, where classically we found 1.5 to 2 millimeter. So a limiting in early implant bone loss, and probably a better way we could get two implants closer to each other and still get away with good aesthetics. So let's sum it up. Implant design, nowadays the literature is in favor of control the biologic width and microgap. And to do so, we have to use platform switching type of implant and the conical seal connection. Showed and proven by all these studies that it is the connection that leaks the less and microbial leakage is the less, and obviously preserve more bone. We have to control the crestal stress distribution around implants by using microthreading, and also limit early implant bone loss with a limited polish color. Now, some of the implants that are placed subcrestally are designed to be placed with no polish color. However, we do favor having some kind of a polish color for the right establishment of a epithelial cuff. Subcrestal implant also is in favor for implants that are designed to be so. Not all implants are designed to be subcrestal. Now, what we wanted to observe is we wanted to compare 3 different implant systems and try to evaluate the importance of macrogeometry and surface texture especially bone stability, and in secondary also observed the prevalence of periimplantitis. So we completed a study in our office. This type of study is a prospective cohort study that included 110 female and male subjects. What we wanted to know is primary changes in alveolar bone height around different implants, and secondary changes as the prevalence of periimplantitis. The rationale is quite clear to all of you guys. However, we can repeat it. We all know today that better results can be obtained with platform shifting, micro grooves, conical seal, and limited highly polished color. And when these are added to the marginal implant configuration. So we want to see if there's a difference in between different types of implants placed in similar clinical situation in the same patient. So patients were included that had one or more missing teeth, that had implants placed previously and needed another one, obviously. Smokers, light and heavy, controlled, diabetic or hypertension, patient with a history of periodontitis, non-compliant patients, regular and non-regular follow-up. Obviously, we try to mimic the most of the real world, and including a lot of patients that were our patient pool. We excluded, obviously, patients that had uncontrolled systemic diseases. We used Tukey test to compare, and ANOVA to compare the mean loss of bone on the distal and mesial side. And Fisher exact test was used to compare the percentage of failure and periimplantitis occurrence. So, bringing down the study diagram, we had 110 patients, 73 females and 37 males, all distributed with 215 Straumann bone level implant, 219 Brennemark implant with an external hex, and 110 Nobel Select implant, internal connection with 1.5 millimeter polished color. These implants were observed more or less the Straumann for a period of about 4 years, in average 2.44 years. Brennemark was obviously observed for much longer, 19 years, with an average period of 6.5 years. Select were observed for 6.25 years, in an average of 2.6 years. So a significant amount of time was given for the observation period. 544 implants were used in comparison with the same type of comparison that falls into the protocol of the study. In comparison, in maxilla, we had 97 Straumann, 66 Brennemark, 76 Select implants. In the mandible, we had 118 Straumann, 153 Brennemark, and 34 Select implants. The distribution of Brennemark implants, this is regards to the sites, with the numbers up top are the international nomenclature of teeth, and you see a quite even distribution of the implants, which makes the sample much more valuable. Here in the mandible also, about the same sites, about the same number of implants in each site. Here for the Straumann implants, also quite similar distribution. And for the Select implants, quite similar distribution. So the sample was good. We had a good distribution, we had a good number of implants, and we had a good observation period. What we did next was standardized X-rays that I will show you later, and where we measured on each implant the level of the bone from the marginal level, meaning the implant abutment interface, till the first peak of bone that we saw on the mesial and distal side. This is a chart that everyone wants to see. What was the difference? So we observed in average 0.72 or in 0.77 on the mesial millimeters of bone loss on the implant of Straumann bone level, 1.51, 1.56 on Brennemark implants, and 1.56, 1.51 on Straumann on the select Nobel implants. So obviously less bone loss with Straumann bone level, probably because of its macrogeometry, less, more evenly distributed forces with internal connection and a limited platform shifting. So statistically, it was significant. We found a difference between these three implants systems. Now, is it relevant clinically? We have to see later on. Here, just to look a bit more in our numbers, we compared the failed implants with the three different systems. There was not a big difference. Peri-implantitis occurrence with the three different systems, and there was not a big difference, statistically significant. Some of the implants were had GBR, got bone regeneration done, sinus lift completed also on three different implants, on three different brands of implants. So the question that is very important to us is implants with different macrogeometries do fail. They fail about the same in our study. Here we looked at the number of patients in regards of the follow-up. 7 patients were lost to follow-up, 36 were not regular, 15 were once every 6 months, and 53 were once every 12 months. So most of our patients came at least once a year. 7 were only lost to follow-up. Now we try to see the occurrence of peri-implantitis in regards to these follow-up. Now obviously, as you can clearly see here, the more you came, the more the follow-up was regular and done every 6 months, the less problems of peri-implantitis and failed implants were observed. Also, we looked into the type of prosthesis. Was it cemented, screwed, or is it multiple or single? We also found that here there was no big difference between a screwed retained or a cement retained prosthesis. Now it's important also to note that all the cement retained prosthesis were done by specialized prosthodontists, and they made sure that there was no excess cement under the gum, which is the #1 cause of early peri-implant bone loss when it comes to cement retained prosthesis. Screw retained versus cement retained didn't make a big difference in our study. Here also comparing the type of prosthesis, which is multiple or single. Are the multiple implants more prone to peri-implantitis than single implant? The difference was not so big. Obviously, 4% of the multiple implants had peri-implantitis, but 4% of 127 implants. So statistically, it wasn't significant. Also, we looked at the smoking habit of patients. We had 17 smokers versus 93 non-smokers. We found out that within smokers, they were more prone to peri-implantitis and more prone to failure. This is a glimpse of what we did, showing, let's say, for example, a patient that has one side a Brennemark restored implant, that we replaced the other side, contralateral side, with a Straumann bone level implant. And we compared this 36 months for Brenmark and 24 months for Stroman. Same here, 32 months for Stroman on the mandible versus 37 months for Brenmark select combination in the maxilla. Another case here where we use single implant in the maxilla versus also a single implant of Brenmark in the mandible. And you can see here very similar results on both type of implants. Here also another case where we have 27 months for Stroman and 61 months for Brenmark in the mandible. What we did also is important to note that we used a program that is digitized and we measured it on a computer screen. It's a program that is done by the University of San Antonio. Another case here where you had a peri-implantitis case, you had them both on Brenmark implants and Stroman implants. The literature on this topic is, of course, very plentiful. We have a study done in 2012 comparing different connections with the same, with two different implants, the osseous and the inhex. Found out that the difference was very minimal. With the same type of study also, they placed 3 different implant brands in the intraforaminal area, about 240 implants in 120 patients, and they found out that the location of the macro gap and the rough, smooth interface was not to be shown to be a major contributing factors in determining the marginal bone level around implants. So our conclusions is that statistical difference in mean mesial and distal bone was significant between Stroman and Brenmark and select, obviously in favor of Stroman bone levels here. No differences between Brenmark and select implants. Platform switching and internal connection helps reduce peri-implant bone remodeling. Obviously, the irregular follow-up and smokers are more at risk of peri-implant failure. However, the question is that is there a clinical difference and in between all these cases? This should be investigated in future studies. And I thank you all for your attention, and I hope that we all tune in together next month with our endodontic webinar. And thank you all. Hope to see you soon.